Okay, so now we have an 85 years old female with a BMI of 21 km per square meter. She has shortness of breath and fatigue the last 6 months, and she was taking up to 245 furosemide per day, and she had multiple hospitalizations for and pleural effusions, drainage before MTIR. 1 year ago or some months ago, she had MTIR with a Pascal ACE device and no need for rehospitalization after that. She had also chronic atrial fibrillation, chronic kidney disease, PPM, chronic artery disease. In the previous coronary angiography, she had a CTO of the right coronary artery, past PCI in LAD and left circumflex artery, with a moderate ISR in the last of the LAD at the last coronary angiography. Here we see the screening, the echo screening. She had a severe tricuspid regurgitation. It is mainly considered atrial functional TR and related to the pacemaker, as you can see, with an error of 0.4 square centimeter. And from the transesophageal echo, we can see a 3-leaflet anatomy with the pacer wire posteroseptal and mainly a significant tricuspid regurgitation from central and posterior area. Here we see the CT scan. We can see the dilated right atrium and the right ventricle and the lead, the pacemaker lead. And the posterior side, also we can see from the CT scan the truly tricuspid valve and the length of its leaflet, anterior posterior and septal. Here is the Lux valve that we decided to proceed with the anchor tongue on the ventricular that goes on the ventricular septum, the grasping clips, and the fabric skirt that is used to reduce the paravalvular leakage and fits onto enteral wall. And here we see the procedure. I don't know, Mr. Sparias want to...
My comment on this here is that this lady has an impeded posterior leaflet by the pacemaker lead. It was obvious. That she was rejected for evoke because of IVC offset. So the plane of the IVC to the plane of the annulus were really apart, and the secondary flex of the evoke system wouldn't be enough to make us perpendicular. So it's not only the sizing considerations, but also the anatomy of the IVC in relation to the annulus of the tricuspid valve. So no TEER option here because of impeded leaflet, and no evoke option because of the IVC offset. So we had to search for compassionate therapy with another valve, and Lux valve was available, and the screening was okay for Lux valve. So we proceeded with Lux valve. So this is a different approach. It's a jugular approach. So we go from the jugular vein, and initially we have a wire into the RV. We do an RV angiogram. This is different from the evoke. Just to see the plane of the tricuspid annulus, you see our Chinese proctors, and this is the way they have done hundreds of cases, so they are very experienced, these guys. And then, as you see, the capsule, which, if I remember correctly, Dionysus is 38 friends. 33 friends. And it comes from above and without a wire. Initially you have the wire, but then you retract the wire. So the capsule is wireless. And it has just one flex, not two flexes like the evoke. And by using a combination of flex and advancing the system in and out, and also torquing the system, clock or counterclock. Basically, you achieve the same movement you can achieve with a Vogue coming with the two flexes from the leg. So very similar. And then you release first there are two hooks, as you can see there, that go behind the lateral leaflets in a similar fashion with the Evoque, but only two. So this makes echoing less complicated, complex, Mike?
Yes, indeed. The anchors that this valve has is two, something like they call it rabbit ears, but once they are exposed, we have to check on biplane imaging that the lateral leaflets, anterior and posterior, are above these hooks. And once they're above, and we confirm that, then the next stage is to open the valve, which is opened in a very rapid sequence. Subsequently, what we need to do is to essentially adjust the depth of the valve and make sure the atrial flange is opposed to the base of the right atrium. And at the end, the very critical part and very interesting part is when there's a hook that is going to be pinned to the interventricular septum, and we have to carefully guide that with echocardiography. And I'm not sure if we have that sequence but it's a particular anchor that gets nailed, in a sense, into the ventricular septum. And that really stabilizes the valve position.
I think we have it in a separate slide.
We have it in a separate slide later. Here, we can see the ventriculography of the right ventricle. Sorry. Here. We see there the delivery catheter advanced near the tricuspid valve and then into the right ventricle. We have to make sure about the coaxiality and the depth assessment into the right ventricle. Then here we see the clasps, the paddles, exposed, and we have an assessment. Yes, here.
So here.
Okay.
So here you see the two hooks that are opening in a similar fashion with the Vogue hooks, and you see this pad here. That there is a fabric here. All this is a fabric between this nitinol frame, so this valve stabilizes at 3 points: the two hooks, and then the pin that comes through the fabric to the septum.
Okay, and now that the paddles are exposed, we have the assessment of leaflet engagement. And here again.
So here is very similar to like Triclip or Pascal. You check the arm of the hook and you make sure that your leaflet moves above it.
Here's
you see the anterior,
the valve expansion, and also. And here what Mr. Chrysoheris said before about the anchor deployment in the mid-septal area.
So here you have to make sure that this pad, you see the two nitinols here, it's compressing the interventricular septum. There is no space between the pad and the muscle. And once you see that, here you see, you advance this catheter that is connected with sutures there, and you see how, in a moment, these 3 hooks, very tiny, they come out and they pin the fabric on the septum.
And here is our final position and the result with no regurgitation, and the 3D images also after the Lux valve release.
Congratulations, very excellent case. And actually, which fluoroscopic position is this? Right anterior oblique or AP for the tricuspid?
This is RAO 20 to 30 degrees.
22, okay. And one another question. In both cases, I think the ICD-related cases, good selection for the TTVR, but we saw no regurgitation, zero regurgitation. This afraids you or not? In general, question.
First of all, in both the Evoque and this case, you see how the pacemaker wire is pushed apart by the frame of the valve without any problem. That's why you need to have a redundancy in this pacemaker lead, and we always check, of course, the parameters, the pacing parameters before, after pre-discharge, and 1 month afterwards. And the valve, the position of the valve, it's critical, so we have to check on fluoroscopy from various angles that we have good position of the valve is not constricted. And then the RV function, supposedly we check the RV function before we make the decision. You know, a severe RV dysfunction is not accepted. But we had cases with moderate RV dysfunction, and our experience said to start milrinone in these cases during the procedure, just a preemptive movement to prevent or to help to reduce the possibility of RV dysfunction.
As we did in this case.
Very helpful comments, okay.
Congratulations once again. One more comment. You pointed out that anatomical features led you to choose Lux valve for this case. Are there any anatomical issues that you would choose Lux valve instead of Evoque, apart from what you said about the IVC? And what degree of paravalvular regurgitation would you accept in these very complex cases as okay? What do you say?
Ideally, no. That's why we select a valve and we're not going with a Kypr. So I think that is the target, the aim, when you go with a valve, to have zero tricuspid regurgitation. Because from all those studies we know that even moderate residual regurgitation may be a prognosticator. So, but we have to correct the cases anatomically and also clinically, for sure. And let's move to
yes, I want to
case
invite Dr.